Oh, wait. Hi.
Are there people on the
We're on the air. We're on the air.
Okay, good.
Hi, everyone. Welcome to Fertility Talks. I'm your host, Mary Wong, and this is live post number 117. Today is a very awesomely timely conversation, and I'm so thrilled to have Dr. Paul Magarelli with us today, again, for the second time. So before we start, we're talking about, and I love the title, you created this title. I love the Implantation, the Final Frontier, which is so Star Trek and so appropriate.
Exactly.
Yeah, so before we get into the meat of this discussion, I'm gonna just share with everyone who you are. In fact, you know what, if you're joining the first time, I think I should tell you who I am first. So I am a traditional Chinese medicine practitioner and acupuncturist in Toronto. I'm the founder of Alive Holistic Health Clinic. I'm the author of the book Pathways to Pregnancy, and I'm your fertility coach. So I love to do these talks every week because it's a way of giving back and sharing good, solid information that you can trust versus you just going crazy on Google and going down this bad downward spiral. So here I have Dr. Magarelli to give it to you straight. He is a reproductive endocrinologist and fertility doctor in Colorado Springs. He's been practicing since 1998, so very young. And he's a founder and medical director of high quality, affordable fertility centers and reproductive medicine fertility centers. He is a clinical professor at Yosan University in LA, California, where he teaches PhD TCM, meaning traditional Chinese medicine candidates, Western medicine with integration with traditional Chinese medicine. He is a founding advisor for the American Board of Oriental Reproductive Medicine, so that's ABORM. And Dr. Magarelli has presented and published groundbreaking research in the area of integrating TCM and Western medical treatments for infertility, forging the way for the future of integrated reproductive medicine. Love that. And his book chapter, Revolution in Assisted Reproductive Technologies, the Role of Traditional Chinese Medicine on IVF Outcomes, through Cambridge University Press. And
Well, it took me a little bit of time.
bizarre. I don't know why we're losing connection. Okay, I'm back.
I'm up.
Right? You're good?
Sure. Yes.
You see me?
You.
Okay. Okay.
Well, thank you for that wonderful introduction. I truly appreciate it.
Oh, absolutely. And it's so great to have you back for the second time. The first time we talked about what you are currently doing, which is high quality and affordable care when it comes to fertility. And we did an interview on my live post 98, if you want to refer back to that, guys. So which means you scroll down. And but right now we're going to talk about implantation. So tell us about the current status regarding uterine implantation of embryos. Certainly when I was doing IVF, almost a decade ago now, some of the stuff were not available. The only thing that was available at the time was endometrial scratching. And as I told you just prior to us coming on, I'm like, I don't think it does anything. And you agreed.
Well, the reason I said it's the final frontier, it has been the final frontier for many, many years. Actually, it goes back to 1986 when Ronald Reagan was president. At that time, it was politically profitable to him to stop any and all research on the implantation of embryos. Prior to that, we had NIH funding, and we could look at that window of implantation, or we could look at the embryo-uterine interaction. And so there's been a big black box for decades, many decades now, and many other countries have now banned that type of research. So for our dear folks who seem to have difficulty getting pregnant with today's newest technology, which is IVF with pre-implantation genetic testing, and they put in normal embryos and it doesn't work, everyone's perplexed. And the reason they're perplexed is we seem to have we have solved many of the problems of embryo growth and embryo selection, but the uterus has not been clearly understood or scientifically investigated. So what that leaves us with is a lot of ideas that are very difficult to prove, but thankfully, there's increasing information today that says that we can help. So let's go over the process of what our IVF folks should insist upon prior to doing an implantation. Well, first and foremost, they have to know that a healthy body is a fertile body. And of course, in traditional Chinese medicine, lifestyle, the way the rest they have, meditation, removal of stressors, utilization of techniques to get in touch with their bodies, moving qi blockages through acupuncture, or nourishing various aspects of traditional Chinese medicine's understanding of the human body become critical for implantation to occur. An unhealthy body, alcohol, tobacco, street drugs, legal or not, overly stressed, not enough hydration, not enough sleep, they actually are paramount importance in implantation, because that's the relationship with this parasitic embryo. It's going to attach to mom. It wants to attach in the most favorable environment, and the body knows what that environment is better than any practitioner. So first and foremost, a healthy body is a fertile body. Secondly, if you're going to get an implantation into your uterus, you want to know that there's nothing obstructing inside that uterus the implantation process: polyps, fibroids, scar tissue, old scar tissue, remnants of miscarriages. Well, this is called a diagnostic hysteroscopy. I call it a pap smear with a telescope. You're basically looking inside the uterus and you're looking at the uterus and saying, okay, is everything, all the parts there? Do we have any extra parts that are getting in the way? So a lot of times folks get one uterine evaluation at some point in their infertility journey, and then years go by and they never assess the uterus again. And unfortunately, every month can change the uterine environment. So make sure you have, and again, I'm kind of backing into this implantation question, because when I thought about this, there's a lot of things you can do that don't require science. They just are practical things you can do. So doing a hysteroscopy is critical. Look inside, make sure it's okay.
Yes.
We're very,
Yes.
I'm sorry.
No, I'm just
sorry,
in agreement. Yeah.
Yeah. So once you know that, healthy body, fertile body, uterus is fine, I'll tell you the end of the story, and then I'll bring you to that end again. The end of the story is that right now, I think endometrial receptivity assay testing, the ERA test, is a very good way to personalize your experience in attempting pregnancy. What do I mean by that? Well, historically, the ERA test, which is not many years old, would help 1 in 4 couples. Well, now there's enough data, 50,000, 100,000 patients, where it really does help 1 in 3 couples. So that's a 33% of the couples who would not get pregnant and not know why. This test will tell them why. It'll tell them that their implantation window, which is very tight, is different. It's unique. And most of us like personalized medicine. We like our medicine to be for us, but the vast majority of centers treat patients cookie cutter with progesterone because it works. 6 days with frozen embryo transfers, 6.5 days for fresh embryo transfers is what is needed for progesterone supplementation to be ideal for that implantation window for most couples. But when you get to the IVF process, especially if you get to the point of making chromosomally normal embryos and getting them tested, every one of those embryos are so precious, you really don't want to miss out on success if you only have maybe 1 embryo or 2, simply because you didn't know that for you in particular, you needed a half a day more of progesterone, 6.5, or you needed 4.5 days of progesterone to create the perfect implantation window. So how does that work? So what the endometrial receptivity assay does, it actually, we do a cycle where we actually do the exact cycle we're going to do to transfer. And on the day that we would have transferred, instead of putting something into the uterus, we actually take something out. And that's a piece of endometrium. That gets screened through a microarray for 263 different genes that have to be perfect for the implantation to occur, off kilter. So if you in particular need 5 days to get in sync, and another person needs 7 days to get in sync, this test will say exactly how to dial that in. And that will increase, for most couples, they're like 1 in 3 people will get pregnant who wouldn't have gotten pregnant. And I can tell you in my practice, it is exactly 1 in 3 people that are helped. It's remarkable.
Interesting.
So that would be, yeah, so the end of the story is that's a really, really contemporary, demonstrable, statistically significant, good randomized controlled trial studies have been done, and increasingly more are being done to say that that's efficacious. So definitely do that.
Okay, so then let's back this up so that people actually understand this. So to walk people through, so this means that you're testing, it's like the cycle before you actually do the transfer, correct? It's a mock cycle. Correct. Just to be
a mock cycle.
Yeah.
Yes, and you know, we use that cycle to learn lots of things in terms of how the body responds. The second area of helping implantation, which I honestly never did because I didn't think the data were there, was the endometrial scratching. It became somewhat famous by the doctor who did the Octomom. That's what he was famous for. He has since, of course, lost his license for other reasons, but and there was this impression that if you damage the uterus, when it heals, it'll recurrect and then enhance your chance of implantation. So you would scratch it, it would heal from the scratch, and then not very good studies.
You're freezing
when I say
up.
not very good studies, they're not randomized controlled trials. And so finally, a huge randomized controlled trial out of Australia has definitively demonstrated that it does nothing. It does not contribute to improving implantation. That doesn't mean it may not have other functions, but when a patient is coming in and you want to do the most efficacious treatments that are proven, endometrial scratching today, it doesn't have the data.
Yes, and some people are still offering this. So for those of you that are being offered this, just know this. It's your choice, right?
Well, go on the studies. You can download the study. It's accessible. It's all over the internet now. It's a good study. It's a large study. And Cochrane Reviews out of Canada, of course, suggested it might help. But I think with this new data, Cochrane will go back. And my suspicion is that little bit of benefit that they thought might happen doesn't happen. And again, in science, you have to understand we have no definitive answers.
No.
We have great questions. We have good suggestions. We don't have truth. We have close to truth. And what I want you to do as an audience is just ask good questions and make sure you know what's out there. Another area I'm sorry.
I was just going to add in again, which again, I told you before we started that when I went through fertility cycles, the IVF cycles, I did endometrial scratching because that was the only thing they offered at the time. So of course you do it, right? And the time that I didn't do it was actually the time that I conceived our child. So again, you know, take it for what it's worth.
An N of one, and it may be right.
Yeah.
Yeah.
Okay, so the next, you said you're going to talk about the next one, matrix, yes?
And I'm kind of going with the hot topics first, and there's many other topics.
Yeah.
Right now, the next top topic is PRP, plasma-rich platelets. And as a matter of fact, on ABORN, there's a couple of discussions about this today, and I wrote back to them, and PRP has been used in the dental industry a lot for socket diseases. It's being used more and more now in orthopedic surgery. And what it does is they're growth factors And what they do is they augment the body's growth factors with the hope that it's going to improve tissue regeneration, improve vasculature, again, for tissue regeneration, maybe provide the tissue that was absent, in other words, stimulate tissue growth. And it's been used a lot in dental, it's been used a lot in orthopedics, it's used in many other, but OBGYNs are just dipping their toe. And there's two areas where PRP has been in very, very small studies shown to be efficacious. One is, one of the hardest things for us are patients who can never get their uterine lining thick enough, which is above 7 millimeters, with the medicines we give. And I can remember for a long time they recommended Viagra, a nitric oxide inhibitor. Then they recommended acupuncture as a way of improving blood flow. They've recommended many different ways of solving this cell therapy, which is done in France. They have an IRB study there to try to get that lining to be thicker. Well, recently, in a couple of papers, they've demonstrated that with the addition of PRP, small study, very small study, 15 in one, 5 in another, they had significant improvement in not only the lining, but and again, these are not good studies because they use historic controls. And again, I'm always saying they're not good studies, but they're interesting. These women never got pregnant. They were given embryos, and embryos failed up to 5 times, never got pregnant. And then with the addition of this PRP, platelet-rich plasma, they were able to grow the lining, and every single patient got pregnant. Every single patient in these studies. Now, that's really encouraging, but again, as we see at ABORM, the discussion, some people are charging $5,000 to inject a couple of milliliters of your own platelets into you.
Yes.
I'm very sensitive, high quality, affordable, so I want the high quality, but I don't know if there's enough data. But if you're in a situation where you don't have any other choice, I'm intrigued with that option. I'm not doing it in my clinic yet. It takes me 2-3 years of reading studies before I introduce anything, but it's provocative. So that would be PRP. Another area that I'm finding interesting, because I have found it useful for my IVF patients, in the past 20 years, there really haven't been any changes in the protocols to stimulate patients for IVF, and especially poor responders. The only factor that seems to benefit patients who are poor responders is growth hormone. So right now we have a protocol, the growth hormone CMAP protocol, which is growth hormone plus the Credenda Magarelli acupuncture protocol. So I'm combining East and West. And we have shown in our own clinic, and others have shown this, and Cochrane has shown this in his analysis, is that we can get an additional embryo and an additional maybe 2 or 3 blastocysts utilizing growth hormone. The reason I'm saying this is now, after 1.5 years, that's part of my standard of care. Well, recently there's been 2 studies looking at growth hormone during the time of embryo transfer, which I kind of quirked my head and said, I wonder. And apparently there are a few centers studying, and it's IV growth, it's IM growth hormone, it's injectable growth hormone, it's sub-Q, but not in the uterus. So it's growth hormone protocol. It's a pretty straightforward protocol. And we do that for patients who have, again, we can't figure out why they're not implanting. So endometrial receptivity assay says fix the progesterone. The use of PRP says add growth factors in there to get that luscious lining you need. Maybe that's the reason we have implantation. Growth hormone also provides growth factors, of course, growth hormone. So that may be the mechanism.
And so how does that work? Like how is it just a one-time shot, or is this a daily thing?
No, it's a protocol. And the protocol is, it's 1 international unit or 2, because there's 2 different studies, every day, the month before and during the process up to it into the frozen embryo transfer. The reason they don't give it after is because, of course, you're not going to give growth hormone to a woman who's pregnant, right?
That's right. Yeah. Oh,
Right. So you'll do it
interesting.
up to the point of transfer, cross your fingers, and then you go from there. So that's, again, another protocol.
So I have another question. So I have
Yes.
another patient who is the RE is asking her to do tamoxifen to help with her lining. So a cancer drug. So what is that all about?
Okay, so tamoxifen is clomiphene under another name.
Hmm.
Clomid, tamoxifen, clomiphene citrate, tamoxifen, is a estrogen receptor blocker. So help me understand this, Mary. If I need estrogen to grow the lining of the uterus, and I know that if I give Clomid for more than 3 months, it thins the lining to become a contraceptive.
Exactly.
How does adding to an estrogen receptor, a selective estrogen receptor blocker, I can't find in my brain the logic. So I would ask the reproductive endocrinologist, where are the studies? Please show me the studies. And why do I fit into this protocol? Most of the time it's because, as I said, implantation is a black box. So they're trying to help. We're trying to help. We can't test what works, right? We're not
Yeah.
allowed. We're
Yeah.
not allowed to test what works. We're not allowed to talk, mess with the embryo, mess with the female, mess with that interaction. We're not allowed. So you try to approach it from as many angles to be able to see what's in the box. So maybe, and again, I would apologize. I've never heard of that treatment, but he may have a different reason, a different mechanism because he wants to help. And that's usually the motivation, is people want to help. And especially if we're not allowed to study something. So this is a shout out. Please vote for us to study this stuff. The best we can do as scientists and doctors is try to approach the logical reasons why it would work. And that's why I said with the estrogen receptor assay, the ERA, receptivity assay, that makes sense because that's personalized medicine. I'll buy that. The PRP, miraculously, with joint issues, back issues, dental issues, improve, and which didn't grow before. Okay, that makes sense. And they've now had studies showing it grows. With growth hormone, the mechanism is rejuvenation, right? Mm-hmm. Longevity medicine, rejuvenation medicine, the number one ingredient they add is growth hormones for all your processes. Why wouldn't it help the uterus? The stem cell therapy in France makes the most sense for women who have Asherman's and have lost the endometrium. If you can get that endometrium to regrow, you're not fixing implantation, you're creating the only opportunity for implantation. It's not like a magic drug, it's simply letting you regrow your lining. So I think that's how PRP helps. I think that's how growth hormone helps. I think that's how stem cells help. Stem cell therapy helps. So categorically, if we were to end this here, we don't have to, I would say those are your best options. Lifestyle, the ERA. If you've frustrated all those and it's still not working, PRP. I don't feel, I'm going to be doing some work with growth hormone over the next year, kind of reading more, looking at it. I have seen it help my patients get eggs and embryos, so maybe it can help their implantation. I don't know. There's a gigantic list of other therapies, but most of them, I'd say, almost all of them have no real solid data to support them.
Okay, interesting. So, because for example, Matrix is done I think right before implantation. Okay, what do you have to say about that?
Oh my God! Oh my God!
Okay, tell me. What are your thoughts?
Oh my God! You probably want to cut right now. I'm sorry. It's just oh my God. No, I just did anyone. I went to the website. I never heard of it. And what it says is an individual has many years of experience clinically. That's what it says. I couldn't find any studies. I couldn't find any data. They said, look at how remarkable this picture is from that picture, but it was like the before and after pictures with guys who stick their stomach out and then they hold it in and say, look what happened. I didn't see any differences. And that's my personal opinion. I mean, I've never used it, never tested it, don't know anything about it. But
Okay.
the first place I look is and I wish my patients would do this, look at the reference list of the procedure, not the awards that the doctor got. Look at the publications. Clinical research without publications is meaningless. You have to have your peers, your educated peers, work with you to understand why you think it works. Now, it's a black box. So if they found a visual marker, because that's what they're saying, it's a visual marker to say what's right and not right, at least that's my understanding, is we'll tell you by sending us the ultrasound pictures whether this one or that one is right. I mean, the answer is why not? But show me the large randomized controlled international studies, different types of patients, different BMIs. I can change the picture on my ultrasound with the twist of my wand. I can make a picture look one way with the twist of my wand. And it says that in Matrix. Yes. It says it's operator dependent. So I did look at it, and it actually was, thank you, because it got me, I never knew about it, and I hope there are people who know more about it, but I could, on first blush, and it is first blush, I went, yeah, I get what you're trying to say, that there is a morphological picture that you see. It's called TriLamina, a TriLamina uterus, right?
Yes, yes.
And the way to remember that is you want it to look like Mick Jagger's lips. That's what you want it to look like. I tell my patients, this looks like Mick Jagger's lips. It's perfect. You know, from his album with the tongue, it has to look like that with the big mouth, the tongue. It has to look like 3 layers. Mick Jagger's lips. Okay. Check it out. But so you want to have that trilaminar appearance, because that means that all the blood vessels are right, the growth is right, the demarcation is right, estrogen is being secreted, lubricating, everything is right. And so that's what my impression is of that Maestris program. So I don't know. I think this is to say how it can help. I just couldn't find anything on their site. And I did do a deep dive into Google, and I actually didn't get anything that resonated with me, and that may be my fault. So I don't know.
Well, but I love that response, because I think that's what people need to hear. You know, coming from a professional versus like I say, everybody else go on their little chat groups and ask, and I just don't think that's a great way of getting good information. One last one. There's another one that they use in Canada. So it's called the endometrial functional test, which they're claiming is different than ERA. I don't actually understand how different it can be, but
yeah, so I didn't know what the EFA was. Do they take a biopsy when
Still
they
the
do
same.
that? Do they?
Yeah.
Okay.
Yeah.
Okay. So let me help you. We keep saying the word ERA, endometrial receptivity assay, but that's a trademark.
Exactly. That's what I was thinking. Yes. Yeah. Kind of like Kleenex box, right?
Correct. Cooper Genomics came out with a new one called the ER test. And I just read a wonderful paper out of France where they're challenging the need for, like, I think ERA is 263 genes. My understanding, and I may have this wrong, that Cooper Genomics is looking at 163 genes. And this person in this research institute in France is saying, well, maybe we can get it down to 5 or 6 genes that really determine the most critical. Let's say it helps 85% of the people, but instead of spending $1,000 for an ERA, let's spend $100 for looking at 2 genes instead of 263. So it may be, and I don't know, that the EFA is just another company looking at another group of genes. And by the way, there's not right or wrong, there's data. So if you find a reference or a paper on this, or even if you can send me the protocol, but because I'd love to read it, it may well be that there's a Canadian company looking at some of these genes and are saying, no, we think these are critical. No, we think these are critical. So it may be that the endometrial. I've never heard of that. I'm sorry. I don't
No, that's
know.
okay. That's okay. So one other thing I actually want to address too is like I just want to say it out, put it out there, and you know, we try to look for the truth, and you try to help, and I mean we all try to help, but I also don't want to bypass the fact that not all chromosomally normal embryos are actually a baby. Would you agree?
That's the last point I was going to make. Thank you. Here's the deal. Let me tell you what we're testing so people don't misunderstand.
Okay.
I do this all the time. So if I put in this embryo that's been tested as euploid, chromosomally normal, it's going to be a normal baby. Absolutely not. And I'll tell you why.
Oh, sorry, my printer's going. I hope it won't hear it.
When we do genetic testing of embryos, we're actually just doing chromosomes. We have 23 chromosomes plus the sex chromosomes X and Y. Think of the chromosomes as office buildings, and each office building has 1,000 apartments or 1,000 offices. All we're saying is that the office buildings look good from a distance. They look like a tall building, a short building, a medium building. That's how we line up the chromosomes. They look like good buildings. They say nothing about the genes, which is the offices. So you could have a beautiful building and 3/4 of the offices be burnt out from a fire. 2/3 of them have rat infestation. 4/5 of them have leaky water. You know nothing about the genes. You know something about the buildings. That's number one. Number two, we never test the baby. When you get a blastocyst, if I can show you, right? This is a blastocyst here, right? It has two parts, a baby part and it has a placenta part. Well, we never, ever, ever touch the baby.
That's right.
The placenta cells. So now you hear.
Oh wait, you just cut off for a second, so we're gonna Oh, you're totally cut off now. Okay, guys, he was just saying that. Oh, you're back. Okay, so basically, in terms of the biopsy,
right? We test the biopsy is of the placenta part, not the baby part.
Yeah. Oh, shit,
when
you're
you
cutting
divide millions and millions and millions
Go
of
again.
cells. Oh, sorry.
Okay.
Am I there?
I think you're there. Okay, try it again. Try it again.
Okay.
Try it again.
I'll make it brief. Just because you test the placenta does not mean that the baby is normal. And even if the placenta says the baby that the placenta cells are normal, does not mean that the baby cells are normal. So you have what's called a mosaic, 2 different types of cells. That's in every human. If I were to do all of your 5.6 or 4.6 billion cells, believe me, you'd be a mosaic. You'd have different cells. So part of the limitation of our testing is the fact we are only testing the placenta. And the other limitation, another reason implantation doesn't occur is that the body and nature are smarter than us. Even though it's labeled as normal, it actually isn't. So that's oh my God, I can't fix that. But the bottom line is it does take more than one try to achieve a pregnancy, even with euploid embryos. So you should trust that in the world, it takes 2.6 tries to make a baby, even with euploid embryos. So forgive yourself if you don't get pregnant on the first try, but use some of these other technologies if you have repeated failures. And now in my clinic, I 100% offer the ERA test to everyone, even before their first try.
Great. And that was my next question to you. That's a great answer. Thank you. Yeah. And you've seen increase in pregnancy rates doing this?
I have. Okay. It took me 1.5 years to believe it.
Okay. Oh, interesting. Awesome. Okay. Any last words of advice for the couples or single women doing this?
Yes. Nature wants you pregnant. You're not fighting nature. It's frustrating, but nature wants you pregnant. Persistence, perseverance, That's how pregnancies happen. Knowledge is power. It's okay for you to say, doctor, can you show me the evidence that that will work for me? It's okay. If the doctor knows his stuff, he's proud of you. He's not mad at you. You're not challenging him. You're saying, does this technology work for me? And if it doesn't, I might still try it, but I want to at least know, where does this fit in our understanding of our medicine? And then just the most important thing is, I believe access to care is the most important thing. And so go out there, shop around, make sure because some people are charging $5,000 for PRP, buddy of mine's charging $200. So,
oh my goodness.
Don't be afraid to ask questions and see if there's, go on the internet, look up high quality, affordable fertility centers, and I'll give you all the information on questions to ask and our prices. Everything is there, and you should do the same. Don't feel hogtied into one place, because we're all good. We're all trying to help, but sometimes affordability is really the key to getting the kind of care you need. Mm-hmm. That's it.
Agreed. Thank you so much for being here tonight. And I know that you had a busy roster, and that's why we were late, by the way, guys. But better late than never. Yeah. Don't be sorry. I'm just so thrilled that you made it. And maybe we'll have another hot topic to talk about in a couple of months, and if you're willing.
Of course I am. You guys, good luck to everyone, and get pregnant.
Thank you. And thank you all for tuning in. And do scroll down. And as I mentioned, live post number 98, Dr. Magarelli does specifically talk about high quality and affordable acupuncture. Sorry, not acupuncture. Fertility. So check that out. And next week, who do I have? Oh, we're talking about endometriosis. So we're going to talk about, so that's a great topic, of course. And of course, there's lots of other topics. And for those of you that are Facebook shy and don't want to like anything, just go on my marywong.life and go onto the videos, subscribe to my YouTube channel, and you'll get all of the same videos. Okay, so do that. And one last thing, the Canadian Fertility Show is coming Saturday, February 23rd. And Dr. Kiltz, who you talked about, you gave me the article with regards to, again, more affordable care. And he's another practitioner. He's another REI that does this. So he's going to be speaking there. I'll be speaking there about acupuncture and how to integrate it in your medicine. So please come. And that's it. We shall see you next Wednesday, 8 p.m. Eastern Standard Time. Oh, 8:30 Eastern Standard Time. Okay. Have a great night, and we'll see you soon. Okay, maybe I'll see you at the are you going to IFS?
Yes, of course. I'm talking at IFS.
Oh my gosh, I'm sorry, I don't even look. I can show up.
Transgenerational epigenetics, and why integrated medicine is a great model for that.
Perfect. Awesome. I'll be there. Just so you know, I'm actually I am Canadian, so a lot of us Canadians are not part of the American Board of Oriental Medicine. And when it first came out, I was actually trying to get pregnant, so I had no time to do that.
Are we still live? Are we still live?
Yeah, we are live.
Are we still live?
Totally live. I like to get everybody in on this, so I'm telling everybody that I'm actually going to be writing this exam. Like, I don't have to, but what the heck? Why not? I love, we love to learn and relearn. I call it circular learning. You fill in the nooks and crannies, right?
Love it.
So I'll see you there for that. Okay. So thank you so much. Okay, you take care. Have a great night. Bye, everyone. Mwah.
Good night. Bye.